Now we've got the mandatory radiology lecture coming up. So we're going to turn down the lights, turn on some music. Dr. Ossipow and Dr. Taylor, but happy to have them join us. We were actually working on this lecture last weekend on the porch with a couple of beverages, and I'm not sure where it's going to take us, but I'm really grateful to work with both the diagnosticians and the interventional radiologists here at Piedmont. I mean, everybody talks about sometimes their job just stinks and they want to leave and go somewhere else, and you realize the supportive services of a really focused abdominal radiology team and an IR team you've got to have for pancreas cancer surgery. So I'm really indebted to work with these guys. I know our whole team is. Dr. Ossipow has helped us develop our pancreas staging CT, which we stole from a couple other institutions and has really been a game changer for staging pancreas cancer, which, as many as you know, is pretty controversial. But I'll turn it over to Dr. Ossipow, and the stage is yours.
Thanks, Andrew, for asking me to speak today. We're going to talk about new developments in pancreatic cancer imaging. I'm going to kind of jump right in. I don't have any disclosures. We're going to talk about 4 new developments that were published in predominantly the radiology literature over the past year. The first is isolated distal pancreatitis and increased risk of pancreatic cancer in that subset of patients that present with pancreatitis. Second thing I'm going to talk about is assessment of vascular involvement with pancreatic cancer, whether or not dual energy CT can help. One of the core responsibilities of the radiologist with staging CT is to kind of identify the relationship between tumor and vessels, and there is a potential where dual energy CT may be able to help us with that. Thirdly, locally recurrent pancreatic cancer versus post-surgical fibrosis. This can often be very difficult to differentiate, and there was a paper published recently that discussed utilization of MRI with diffusion-weighted imaging, may be able to distinguish between those two entities. And then lastly, kind of the sexy topic within radiology, which is artificial intelligence and radiomics, whether or not a machine learning model can detect pancreatic cancer in a morphologically normal pancreas that's not visible to the human eye. So firstly, isolated distal pancreatitis. In general, pancreatitis presents where the whole gland is affected. There was a paper published a couple of months ago that looked at about 115 or so patients that presented with pancreatitis. And a small subset of those patients presented with pancreatitis just affecting the tail and body of the gland. In the patients that had your run-of-the-mill diffuse pancreatitis, they followed those patients for 2.5 years, and none of them developed pancreatic cancer. However, in the patients that had pancreatitis that was confined to the body and tail, in their patient population, 64% of them went on to develop pancreatic cancer in the next 2 years. The mechanism here is thought to be ductal obstruction by a small imaging occult mass that releases or activates the pancreatic enzymes. So 2 images from that article. The first image here on the left is when a patient presented initially. That large arrow points to the pancreatic head that's enhancing normally. And the smaller arrows and the curved arrows are pointing to the pancreatic tail and body, which is hypoenhancing with inflammatory change around it. So kind of the classic imaging appearance of pancreatitis, but it's just affecting the body and tail. On this CT, there was no mass or no evidence of pancreatic ductal obstruction. This patient was treated for acute pancreatitis and was discharged. They presented 20 months later, this image to the right with now an obvious invasive mass, essentially replacing the body and tail of the pancreas. That curved arrow points to tumor abutment of the SMA. That angulated arrow points to encasement of the splenic artery. So very locally advanced pancreatic adenocarcinoma. This is another image from that article demonstrating, again, distal pancreatitis. You can see sparing of the pancreatic head, which is enhancing normally, and then involvement or inflammation and hypoenhancement of the tail. This patient underwent an EUS about a month after their presentation, and on EUS, it revealed pancreatic cancer at the parenchymal enhancement transition between normal enhancing head and abnormal enhancing body and tail. I think things to draw from this paper, one of the reasons that pancreatic cancer still has a very challenging prognosis is due to difficulty in early detection. And in this study, there was 174 days was the median interval between the initial CT and a subsequent CT where the radiologist was concerned about pancreatic cancer. So one of the goals is how can we narrow that window between when a patient presents with abdominal pain and may have a mildly abnormal CT, and when they're ultimately diagnosed with pancreatic cancer, to try to narrow the window of diagnosis. And I think one thing we can do is recognize that pancreatitis involving the body and tail is a unique subtype, and we need to recognize this entity so that patients can either be followed very closely with imaging or undergo an EUS to look for an imaging occult mass. The next new development I want to talk about was a paper published a couple of months ago predicting vascular involvement in pancreatic cancer and whether or not dual energy CT may be able to help. One of the most important things we do as a radiologist when we're looking at staging CTs is to assess the relationship between the tumor and the vessel. And in this image here, you can kind of see the standard way of doing this is determining the degree of tumor contact with the vessel. So is it less than 180 degrees or is it greater than 180 degrees? And that suggests whether or not the vessel's truly involved with tumor. Unfortunately, this is it's an indirect indicator. It's not actually looking at vessel invasion. It's looking at tumor contact. And there is some inter-reader variability between radiologists in assessing degree of tumor involvement. And additionally, there are things other than tumor that can mimic tumor, like perivascular inflammatory adhesions or fibrosis, that can lead to an overestimation of tumor involvement. And so what these authors did was pretty interesting. They used dual energy CT. So they obtained a CT at two different X-ray spectral levels, had two different data sets, and they were able to form what they could describe or call dark blood images. So this large arrow is pointing to the SMV, superior mesenteric vein, and that you can see within the vessel, normally there's bright contrast, and in this study, they saturated out or they suppressed the contrast within the vessel. So what you now have is just a nice, thin, enhancing vessel wall. So that large arrow is pointing to the SMV. There's a tumor underneath that arrow that's contacting the SMV there, but you can see a nice continuous wall enhancement. And what they found was that if you have irregularity of wall enhancement or discontinuity of the wall, that outperformed kind of the classic way that we assess tumor involvement of the vessel, which is degree of contact, and ultimately could predict an R0 resection. So this is another patient. On the image to the left, the asterisk is on the SMV, very similar kind of tumor contact. We have about less than 180-degree tumor contact of the SMV. And then the image to the right is the dual energy image, which shows the dark blood image. And you can see actual obvious discontinuity of that nice enhancing wall, indicating that's a direct evidence of vessel invasion. This patient underwent a resection and indeed had direct invasion of the SMV in an R1 resection. So I think just one kind of take-home point from this, as we move kind of forward, CT is going to be the mainstay of our staging, I think for the near term. But I think with some newer techniques, whether it's through dual energy imaging or there's kind of the newest, I think, most exciting development in CT technology is going to be photon counting CT, which is going to allow us to improve upon spatial resolution. I think there are some opportunities to improve for radiologists to be able to kind of improve their ability to provide accurate staging information. Thirdly, I wanted to just touch briefly upon a paper that was published relatively recently utilizing diffusion-weighted MRI for locally recurrent pancreatic cancer after surgical resection. So the issue here is that there's overlapping CT findings on surveillance CT after a surgical resection between tumor recurrence and post-treatment change. So these patients often have gotten chemoradiation, and fibrosis in the surgical bed can mimic a tumor recurrence that can be very difficult to differentiate on CT. And early detection of recurrent disease obviously is important because we want to get these patients on appropriate treatment trials and then assess response to additional adjuvant treatments if they're being given. And so what these authors did is the first image on the left is a surveillance CT, and you can see that arrow is pointing to, I don't know how well it projects from the distance, but it's pointing to some subtle soft tissue surrounding the SMA, so within the operative bed of the surgical resection. And what they found was that for these patients that underwent MRI with diffusion, that middle image is a DWI or diffusion-weighted imaging, and that arrow is pointing to an area of focal hyperintensity or that bright spot. And then the image labeled ADC is pointing to a focal dark spot. That's indicative of a restricted diffusion. And what they found is that fairly highly predictive of a tumor recurrence rather than post-surgical fibrosis. This is another patient with a surveillance CT image to the far left is pointing at an area of soft tissue in the surgical bed adjacent to the celiac artery. And in this case, there's absence of diffusion, absence of restriction on diffusion-weighted imaging. And this is post-surgical fibrosis. So if you have patients with unexplained elevated tumor markers or a new soft tissue abnormality on surveillance CT, think about MRI as maybe helping as a kind of problem-solving tool to differentiate between recurrence and post-surgical fibrosis. PET-CT is often or can be used for this as well, but it's a little bit less sensitive to small lesions, and things like inflammatory change in the operative bed can mimic a tumor recurrence. And so I think the main take-home point from this paper is thinking about a possible role for MRI in surveillance protocols for patients that have had tumor resection. Number one, because it may help problem solve with tumor recurrence versus post-radiation or post-surgical fibrosis. And it has been proven to be more sensitive for detecting subtle hepatic metastasis. And then finally, I want to talk about artificial intelligence and radiomics. I think this is kind of probably the biggest new development in pancreatic cancer imaging. Radiomics is the conversion of digital medical images into high dimensional data. So the kind of the traditional way that I and most of us approach medical images is solely for visual inspection. And this idea of artificial intelligence and radiomics is different. This is not about what we can see, it's about what a computer model can see. And so it's extracting and quantifying imaging biomarkers, so unique characteristics of regions of interest or tumors on an image, and pulling data from them that the human eye can't see. This is a brief flow chart. I just wanted to give you kind of a general idea of what this means and what the goal is of a CT scan. So you have to start with a high quality image. In this case, it's a tumor in the right lower lobe of this patient. You identify your region of interest. You identify the tumor, whether it's in the pancreas or the lung. You draw around that region of interest and you do a three-dimensional rendering of it. And within the region of interest, so within the tumor that you've selected, you run a computer algorithm that tries to extract data from the tumor that the human eye just can't see. It's data on kind of the voxel level, the very smallest level in the image. And once you acquire that data, which it's a unique data from that specific tumor, you overlap that with what should be large public databases of genomic data and clinical data, with the ultimate goal of trying to build a model for prognostication and diagnostic purposes. The heart of radiomics is going to be data extraction, so removing the data from the image. The way that I do it, the way that radiologists kind of currently do it, is we can describe the size of a tumor, we can describe its margins, whether it's smooth or spiculated, and those are the kind of things you're used to seeing in a radiology report. Well, what radiomics and artificial intelligence is going to do is they extract what are called agnostic criteria or agnostic features, and these are mathematically extracted quantitative descriptors of the tumor that the human eye just can't see. They have to do with kind of heterogeneity or randomness within a voxel. You can kind of, which is a three-dimensional space in a medical image. You can kind of think of a voxel essentially as a three-dimensional pixel. So they look at individual voxels and heterogeneity within that voxel, and then they look at the relationship between two adjacent or three adjacent voxels. And if that relationship has been altered due to tumor heterogeneity, that feature can then be used in the machine learning model. And so what does this have to do with pancreatic cancer? Well, there's a paper, a really interesting paper published relatively recently where the authors wanted to develop a machine learning model to detect pancreatic cancer at what they described as the pre-diagnostic stage. So before the patient developed cancer, it was 3 to 36 months before the patients developed pancreatic cancer. Could they look at those pancreases retrospectively and discern whether or not there was an abnormality that the human eye can't perceive? Why is this important? Well, pancreatic cancer can go from clinically undetectable to stage 4 very quickly. And so anything that can help with early diagnosis is really of critical importance. And there are significant differences in survival between between stage 1 and stage 4 disease. So we want to catch patients at stage 1 as soon as possible. And what they found, amazingly, was that the machine learning model that they developed identified very early imaging signatures of pancreatic cancer in a morphologically normal pancreas. So essentially, someone that looked at the CT would say that's a normal pancreas, a median of 398 days before the ultimate histopathological diagnosis. There's a couple of images I'm going to show from that paper. This image on the left is of a patient that presented with abdominal pain, had a normal CT at presentation, and then 8.5 months later presented with a pancreatic mass. The image on the right is of a normal control patient. And when you look at the actual CT images, the standard way we image, each pancreas individually looks normal, and they individually look relatively identical. When the authors applied their machine learning model, and then they for purposes of display, they added kind of a color textural overlay, you can see obvious differences in how each pancreas looks with the color texture overlay. So there is something intrinsically different between each pancreas, but you just can't see it on regular CT. You can only see it via the radiomics model that they used. This is another example from that paper. The two top images, one is an axial image, one is a coronal image of a patient that had a normal pancreas. And then 2.5 years later, image labeled C in the bottom left-hand corner. Unfortunately, the patient developed a pancreatic mass with omental metastasis, so stage 4 pancreatic cancer. And when they utilized their model and went back and looked at the pre-diagnostic CT where the pancreas was normal, their model detected early features of pancreatic cancer, which is pretty impressive. And so what's going on here, this isn't just magic, very early on in tumor development, there is cellular activity that results in heterogeneity that can't be perceived by the human eye, but can be detected by radiomics techniques and by machine learning models. And the goal here is to combine these machine learning models, deriving imaging-based biomarkers with fluid or blood-based biomarkers to find patients that will be developing or have pancreatic cancer and get them to curative surgical resection as early as possible. So as far as, I think, new developments in pancreatic cancer imaging, I think artificial intelligence is going to be kind of the biggest development of my generation and will hopefully transform how we care for patients with pancreatic cancer, allowing us to both stage and diagnose better than we kind of currently do. Thank you very much.
We'll go straight into Dr. Taylor's talk.
Alrighty. Hi, I'm Norrin Taylor. I'm one of the interventional radiologists here at Piedmont, Atlanta. And I will try and speak quickly here and stay on schedule. Although I warn you, I grew up in Montana, which is probably the only place where people speak more slowly than here in the South. So we'll give it a try. So I'm going to be talking about interventional radiology, and we'll explain exactly what interventional radiology is here as an update for 2023. There are three main papers that I want to refer to. One for celiac nerve plexus block, one in regards to Y90 for pancreatic cancer METs, and then another in regards to irreversible electroporation. I don't have any disclosures to go through. So quickly, what is interventional radiology? So this is a relatively new subspecialty of medicine that's pretty derivative upon a derivative of medicine. So I'll try and explain the basics here, but I will warn you in 6 years, I don't think my mom knows what I do for a living. Basically, we do a bunch of different procedures using X-rays, CTs, MRIs, and ultrasounds to look inside a patient while we do a minimally invasive procedure, normally with a single puncture of their skin. So angiography is taking the background image here is what angiography looks like. There's a catheter that's running from the patient's leg up to the main artery of the upper abdomen, and contrast or X-ray dye is being injected there. We're able to interpret those images. With that, we can also inject chemotherapy or radioactive material into tumors. We can go directly through the skin and microwave tumors or freeze tumors. Sometimes we biopsy and other procedures such as that. For pancreatic cancer types, for our procedures, we pretty much differentiate them just into adenocarcinoma or neuroendocrine tumors, but there are, of course, multiple different kinds of pancreatic cancer types. So for these, as I said, these are the main articles that we'll talk about. Irreversible electroporation is the first set of images you see here. That is basically driving some needles that have been designed to emit a current between them. And when that current is emitted over and over in time in multiple pulses, it irreversibly punctures microscopic holes in cells, which causes cell death. We typically would do that into a tumor. It has a relatively controversial use at the moment, but we'll talk about it in just a moment. Y90, we'll talk about a little bit more. That's injection of a radioactive material into tumor. And then celiac plexus block is basically a pain procedure that we can provide for patients. So there's a recent article in regards to irreversible electroporation for pancreatic tumors. The images you see over on the right side are the multiple probes being placed using CT guidance around a tumor. The benefit to this, or why this is used in pancreatic cancer, is there are other ablative techniques where we put something through someone's skin into a tumor to try and kill it are extremely dangerous in the pancreas. Freezing pancreatic tissue is dangerous. Burning pancreatic tissue is dangerous. So the idea behind electroporation is that you use this current and it's less likely to injure surrounding tissue that you don't want to hurt. It's controversial, and it's, I personally am not someone who is exceptionally an advocate of doing this. I think it needs more research at the moment, but this paper is an example of that. And basically what this paper demonstrated was the machine is measuring the resistance between the probes that are placed into the tumor. And that resistance changes over time over pulses. In the first 10 pulses that they measured with this study, they found that the resistance, which is basically how easy does electricity flow through this tissue, it found that those who have large changes in the amount of resistance of the current within the tumor have better outcomes, and on biopsy specimens afterwards, pathologically, they actually found that there are differences in what genes are being expressed on the outside of these tissues. Having said that, I think it points to an interesting prospect for the future, that perhaps there is something we can tell about tumors that will indicate better patient selection for IRE, which is a bit of an issue with it. That's somewhat beyond the scope of this lecture at the moment. The next paper that came out was another recent one from JVIR. This is about Y90. Y90, in case you haven't memorized the periodic table of elements recently, yttrium-90 is a very rare element from Earth that is unstable, meaning that it goes through radioactive decay. And when it does that, it gives off radiation to adjacent, whatever is near it. The nature of that is such that we can utilize it to put it within tumors, and it deposits very high amounts of radiation to try and kill tumors. So the procedure is relatively straightforward. We put a catheter in, as discussed earlier, doing angiography. The images you see here are on the right side of the screen are a catheter up into the main artery of the liver, and then the bottom right image shows where the Y90 has been injected. It's basically impregnated into microscopic glass beads, and the study that was just recently published in JVIR is about doing it for multiple metastases within the liver for pancreatic adenocarcinoma. Overall, unfortunately, it did not demonstrate a very strong benefit for these patients. The main issue, I think, with this tumor is that the tumor type does not tend to have a lot of blood vessels associated with it. Certain tumors do. The main use of Y90 is for liver cancer, which is an extremely vascular or high blood vessel tumor. So it's very beneficial there. But here it appears that the overall benefit is not exceptionally high. And though the safety profile is pretty good, the 69.4% disease control rate at 3 months is not an incredibly impressive result. So I think further patient selection will be something that would be necessary if pursuing Y90 for pancreatic mets is going to be an issue. The next paper I wanted to talk about is in regards to celiac plexus block. This is not a new procedure. Basically, as you can see on the image on the left-hand side of the screen here, we put, this is a CT scan of a patient's abdomen. There is a nerve plexus, meaning a bundle of nerves that supplies the sensation to the majority of the organs of the upper abdomen. In the case of pancreatic cancer, it has a tendency to be a very, or can be a painful type of cancer to have. So this is the nerve collection that supplies that area. In patients who don't have excellent pain control with oral pain medications, we can offer this treatment where we put 2 needles in, inject the little white schmutz you see on the screen there is a little bit of X-ray dye that's confirming our position that we're in a safe place. We then put in some like local numbing medication, and a lot of times we'll see on the table that they have an improvement in their pain, and we can follow that with pure alcohol. And when we inject that, that kills the nerve in the area and effectively blocks the transmission of pain from the abdomen up to the brain, so the patient's unable to perceive it. This study that we looked at, though this is not a new procedure, is the first to this degree of quality, where they evaluated, it's called a meta-analysis. They studied multiple different studies and combined the data together to look at 381 cases as if it was one study. The study used multiple different methods, including using up to an 18-gauge needle, which is I would not use something that large because you're going through, you have a very, very small amount of safe window on these. Having said that, despite that many patients, they did not have any major complications. And as you can see on this graph on the right side of the screen, that is the pre-intervention pain score, which was an average of high 6 for most patients, dropping down to 2 to 3 for these patients afterwards. So it's an extremely effective treatment that in this case did not have any major complications reported. Now there are certainly some minor complications associated with this, but overall I think this is very reassuring. And piggybacking on what Dr. Jackson was saying earlier, I think this is an underutilized procedure that I think allows a lot of benefit and a lot of comfort to our patients, particularly patients who have pancreatic adenocarcinoma. As an additional article here, because I think we have just an extra moment of time here, there was a relatively recent publication in regards to neuroendocrine tumors, which do tend to be very vascular tumors. This is a case report, and it's actually from Israel, but they did a coil embolization where they blocked off the blood flow to this tumor that has a lot of blood flow in it to aid in the surgical resection to try and reduce the amount of bleeding. This is not an uncommon procedure that we do for other types of highly vascular tumors, such as kidney cancer metastases. But in this case, they were able to get a bloodless procedure. So I hope this is something that hopefully would be able to, in the future, be something that we can aid our surgeons to help make their surgeries a little more straightforward for them. The images here on the right side are just indicating that the very large white blob you see in the center of the CT image there is demonstrating a tumor with an extremely high amount of blood flow. The angiography images below are before and after they put some very small metallic coils into the blood vessels to heavily reduce the amount of blood flow that's present in this pancreatic head tumor. I think, personally, I think that this would probably be even more beneficial if you were doing it in the pancreatic tail. But an interesting recent development in interventional radiology for the pancreas, nonetheless. That was the majority of my talk. Thank you all.
Any questions? We have time for one or two if they're. Dr. Zabo. Jerry Springer over here.
I actually use Y90 for pancreatic cancer. I'm a little curious about this study. One is, I think patient selection is everything. Two is we don't really have great biomarkers to know which patient is the best patient. And then finally, I would say when they do the Y90 studies, I feel like they're asking the wrong question. It's not oftentimes I'm using Y90 to extend time off chemotherapy more than anything else, because we have a limited repertoire of therapeutic drugs, and oftentimes they're not eligible for a clinical trial, or they're waiting for a clinical trial. But it might just, not that I'm pushing Y90, but if you pick the right person, like liver dominant disease, relatively stable disease, good performance status, I do think there is some benefit to Y90.
Yeah, I certainly agree with you, and I was probably going a little quickly there. The study there, I think, did not have exceptionally great patient selection, and I think they were trying to increase their N number by including a lot of patients who I think had a very high burden of disease. I think that 3 months, if you're trying to improve time off of chemotherapy, I think, but certainly does make sense. But I think patient selection, and hopefully eventually developing some kind of marker that we can look at to evaluate which type of tumors will be better responders, is very key, because there are a lot. We found relatively recently that a lot of tumors that have previously been felt to not benefit from internal radiation actually do, like cholangiocarcinoma and even non-small cell lung cancer, mets to the liver. So I think personally, I think if with good patient selection, especially when there's oligometastatic disease or oligoprogression within the liver, I think that those patients do stand to have a benefit. I guess the main takeaway that I'm unimpressed with the paper is just the general idea of doing low bar Y90 and giving a really high dose of radiation to, I guess, indiscriminately without good patient selection. But yeah, that's an excellent question. And I agree with everything you're saying there.
We have a couple people from Emory. Marwan, do they do Y90 for these at Emory? No. Yeah. Sachs? Dr. Fleming? Same. Yeah.
Very specific disease. I'm sorry. You have to very specific disease, very limited disease. And again, I don't want to, I think personally patients should be going to a clinical trial or something like that if you're in that situation, but you don't always have that option. So I think Y90 is one of these more underutilized tools if you get the right patient.
Yeah, absolutely agree. And I very much agree with what you're saying about late referral to interventional radiology. Hopefully, as I'm a member of the first generation of integrated clinical interventional radiologists, where we matched into a diagnostic and interventional radiology combined residency. Hopefully, as that continues and there are more and more of us graduating from programs, that'll continue to improve.
I will just say this one caution: with pancreas post-surgical, you can really injure somebody with doing Y90 to their liver after a Whipple or any other pancreas intervention. Thanks, Dr. Taylor.
Thank you. Thanks.
Great.